Hey, Helen here, your host. Great to have you along for the second season of The Beautiful Side of Grief, where we continue to hear from people from all walks of life who have faced or have been involved with heart-wrenching loss and who've come out the other side with so many positives to share with others. I know this may seem like an impossibility for you right here, right now, to be in that space. And believe me, I understand. I lost my own gorgeous 18-year-old daughter and only child in a car accident. Yet, here I am 4 years later, sharing my own journey and those of others in the most heartwarming and joyful way. Each and every one of my guests share their own beautiful insights and their strategies for getting through their grief. And through these stories, I hope you'll find your own way to deal with your grief in whatever form that may take. I'll pop my guest links and any free resources in the episode notes, along with my website address if you'd like to know more about the energy work I do, as that was my lifesaver in my own grief journey. Don't forget to subscribe and like so you can keep informed of each weekly episode. So now let's see who our guest is this week. Today, I have the privilege of talking to a family physician who is inspiring other physicians and patients to be having those valuable end-of-life conversations. Dr. Forrest Jones has been in practice for over 40 years, earning his doctorate in medicine at the Northwestern Feinberg School of Medicine and completing his family medicine residency at Cook County Hospital in Chicago, Illinois. He has worked in multiple practice settings, including self-employed private practice, employed fee-for-service and managed care, hospitalist, and home visit companies. He was inspired to start Caring End while having medical power of attorney for his parents. Motivated to have end-of-life conversations with all his patients, he failed because of several barriers. His efforts to overcome these challenges led to a process with added benefits of reviving his passion and inspiring his patients. He enjoys free time with his wife, Roberta, their children and grandchildren. He also delights in good food, travel, music, and cycling. Thanks for tuning in today for this conversation discussing the importance of end-of-life care, what a plan should include, the barriers to getting these done, and so much more. It is my hope that your journey in grief, whatever that may look like, be filled with love, happiness, and hope. So, Dr. Forrest Jones, an absolute pleasure to be speaking with you today on this very important topic of end-of-life conversations.
My pleasure.
Firstly, I thought we'd start with what set you on the path to developing a passion about having these end-of-life conversations?
There's actually several parts to that. What's interesting to me is I began to see that there's, as far as end-of-life planning conversations, there are really two types. And generally, whenever I talk to patients, my fellow colleagues, or even family members, when we mention end-of-life planning conversations, what they really think and what really comes to mind is a delivering bad news conversation.
Yeah.
We think of scenarios where there's been a catastrophe, a tragedy, a bad, fearful diagnosis, cancer or whatever, and then we have this conversation. But really, when you talk about planning conversations, you're really talking about something entirely different. And this becomes more of a guidance type of conversation. I'd like to know more about what your expectations, wishes, and desires are should a hypothetical situation appear in the future. And
That's such a
plan around that.
Yeah, that's such a good point, because what you first mentioned, that's sort of like closing the gate after the horse has already bolted. And, sometimes people are in those situations where they can't actually communicate their wishes well because of tragedy or, something has already happened. We're going to get into that a bit more down the line. But yeah, really important distinction to be having. And having end-of-life conversations is an absolute passion of mine, because I feel so few people are having these and having these early. So yeah, let's get into that. So what should a good end-of-life conversation look like?
One thing is, especially since doctors have such a limited amount of time, that's unfortunate, but working with that reality, I think it's important not to feel you have to accomplish everything in one sitting. Here in the United States, the Medicare will pay for one visit a year for that purpose. But practically speaking, I never could make it happen because on that particular scheduled appointment, patient might be running late. I might be running late. They might have had a new symptom or problem come up that they thought had priority, because an end-of-life conversation, planning conversation, is really not an urgent conversation. Now, a delivering bad news conversation is an urgent conversation. Pretty much have to set everything aside and, okay, we have to just really face this and deal with it. But an end-of-life planning conversation doesn't have that same kind of urgency, and so we end up kicking it down the road. But if we take a bite out of the elephant, then we can make progress a little bit at a time. And one challenge for us as physicians is, how do you actually document these individual components so they actually come together in a coherent plan that we can actually refer to easily in our medical record system? To answer your question, that's a part of the answer, I guess. If they have not done that, then you definitely want to give them that information, because that's the most critical piece. You want to have somebody who can make decisions, and if you're not able to do it yourself, you want to be able to choose who that person.
Do you think one person, or perhaps two? Because sometimes people may choose their spouse or partner, and if both of them are in an accident together, then we get into that interesting scenario of, neither being able to advocate. So sometimes it's better to have an additional person, isn't it?
Yes, and we will ask, if there's one person, and then if that person's not available, who next? But you do want to have one primary person at a time. And in families, ideally, and not every family is as functional as we would hope, but ideally you want someone who's actually able to communicate effectively to all the other family members, because even though there might be one person we're talking to, oftentimes the decision makers might be more than one. And it can just be a collective decision.
Like you said earlier, many people have the perception that end-of-life conversations are about when there's bad news and things like that. Also, end-of-life conversations are about whether you want to be buried or cremated. And sometimes that's the extent of where the conversation goes. And we need often a little bit more information about that. Like, a good scenario would be, do you want to have all the efforts to keep you alive? Or are you the type of person that says, okay, this has happened, this is my time, I'm happy just to be kept comfortable and let it play out as it will?
That's absolutely correct. There's no one size fits all. It's interesting. I was reading this book. I think I was led to read this on a podcast or something, but The Death of Ivan Ilyich by Leo Tolstoy. Oh, interesting. And I got on audiobook and listened to it. And I would say it was so helpful for me because it helped me to see from the patient's point of view, not just a doctor. It was so well written that I could see myself in a family member's shoes, the doctor's shoes, and the protagonist, the patient's shoes. But out of it, I came with 3 questions that I think my patients will want to know about their overall planning and how that can specifically be relevant to the end-of-life care planning. So question number 1, Doc, how am I doing really?
Yeah.
And so, I'm taking all these tests and we do these annual things and I get my exams and I'm taking these medicines and so forth. But ultimately, how am I doing from your perspective? Question number 2, what does it mean? And this is something that's really a collaborative effort, because if I'm treating you, I want to know, what does this diagnosis mean to you? How does it affect you emotionally, physically? I can explain to you what the impact can be on you physically now and in the future. You have heart failure, for example. These things can happen, and we want to make the best out of it. But I need to know from you, how does that affect you emotionally? Does that affect your sense of self, your sense of mortality? Does that affect your roles if it should get to advance to a more advanced stage where your activities are limited? And of course, as you move toward death, that certainly becomes more and more of an issue. And if your activities are limited and your ability to function become more limited, does that affect your sense of self, your role and responsibilities in your community, in your family? Some people get their whole identity by some of their roles. And if they can't fulfill those roles anymore, that can really almost a crisis situation. I've seen it even in my family with retirement, for example. I have some male members of my family who, because of changes in the economy, their business or whatever, they've had to retire a lot sooner than they had planned. And now they don't really know who they are. And they're having a hard time with those adjustments. But that can happen from illness as well. And so if I have some feedback from you about what that means, and even spiritually, what would this impact on your legacy? Where would you find meaning? Who would you turn to for support, or what institution or faith? Do you have a faith tradition that is meaningful to you that would help you in this time? And this helps me understand. And then you also are talking to me in terms of, well, you want to know from me, how can I work with your treatment plan so that we can get the most out of that? But I find also having those conversations helps me not only to look into the future and how we can put a plan together for the end of life, but really how can we craft your plan so that what we're doing now is more fulfilling for you. So I might ask someone, okay, let's say someone is 78 and Social Security actuarial table says they might have 12 years left to live. Okay, well, age is, that's just a number. But now that we put it in that context, what's on your bucket list? Is there anything that you've always wanted to do that you never got around to doing? And this year, why don't we make that a priority? It's not just, are you compliant with this and that and taking this and that? I'm happy with your blood pressure. I'm happy with your blood sugar. Happy with your cholesterol. Okay, that's all fine and good. But in terms of your life, let's talk about that. And so now we're helping in not only the future, but also the present.
I love that, because that's looking at the person as an actual individual rather than just a set of statistics. And we all know that that's sometimes what happens. You are Mrs. Whoever with da-da-da, instead of a person that has hopes and dreams and, perhaps unfulfilled wishes. I love that. So the 3 questions are, how am I doing? What does it mean? And how does it affect me emotionally? Have I got
that? Something to that? Now, this is where that helps the doctor, because my whole system that I came up with and the online course that I have to go with this is really for doctors. Yeah. I'm a family physician, and so many of my colleagues, like me, went into primary care because we're fascinated with the human body, fascinated with people, and we really want to make a difference. And there's so much about the practice of medicine that kind of separates us from that, and we start to lose our passion. But I'm finding that if I approach these questions, for example, I'm not threatened by them, but I'm actually leaning into this. It reminds me of why I became a doctor in the first place. And this helps to grow resilience against burnout, which is an epidemic now. And COVID has only made it worse, but the issue was there before COVID. And we want to find a way to have our heartfelt healers, our doctors, stay in the game and stay passionate about taking care of people.
Such a good point. So what has been the uptake by physicians? Are they really embracing this, or is it like something more that's adding to their workload, or how are they viewing this?
Very interesting question, because when I started doing my own informal market research, whenever I would talk to family members, friends, lay people, they would say, oh, this is so great. I can't wait. I want to see the book. When is this going to happen? Tell me more, excited. But when I would talk to my fellow colleagues, they would say, that's a good idea. Good luck. And I get it. Because it's like, what do you expect? I'm already overwhelmed. I don't know. And so they're thinking, first of all, about a delivering bad news conversation. And they're also looking at the limits on their time and the fact that there's already way too much to do in that small time frame. And so that would be the initial response. But I have had a chance to teach the course my first beta, and the doctors who were in the course were very pleased because they saw that the system was not one to add on to what they're already doing. It really makes use of what they're already doing. It doesn't require a lot of new information that they have to learn, be tested on. It's really taking what they already know and it's just reworking it, kind of repurposing some things in ways that are more interesting. So just a quick example. Before we go in to see a patient, I hope you don't mind me saying patient. That's kind of
no, that's great.
Before we go in to see a patient, we like to review the chart and kind of get a feel for, okay, what did we touch on last time that we were going to follow up on this time? Has there been any new information? To want to get kind of oriented. Here in the United States, we have what's called a problem list, which is a list of diagnoses that we're managing for our patient. One different twist that I put on this that I learned really helped me was I'll look at the problem list and I would look at what diagnosis on that list I would consider, in my professional opinion, most life-limiting for this person. That's a new way of looking at it. And look at it and say, okay, what's stable, what's not stable? If it's stable, handshake, good to see you, keep doing it, see you next time. But when I look at it in terms of what's most life-limiting, then we can start to build our plan around that as far as end of life, because that's concrete. So if you have heart failure, I hope you don't, but if you have heart failure, there's a certain trajectory to that from where you are now toward end stage. Mm-hmm. So I can kind of instruct you about what those different advanced stages look like over time, because this might be your story over the next 5, 10, 20 years, whatever. So once you get to see that, you get familiar with, okay, I see what this can look like in the future. I'm trying to take medications because I want to give it the best scenario. But at these different advancing stages, we could talk about what type of decisions you might be faced with, what type of complications might occur, and then what type of intervention we would recommend. So CPR would be helpful for the earlier stages, but at the end stage, it won't be helpful. Mm-hmm. A ventilator might be a stopgap measure to help you at some of the stages, but at advanced stages, unless we see that it can help you get over a hump and get restored to a level of functioning, if it can't help that, then you want to know in advance that, and your family and loved ones and decision makers want to know that, okay, there's limitations to these things, and here's where that would actually take place. So we have a chance to quote, and then when we combine all of that with information about how you perceive these impacts at these advanced stages on you emotionally, socially, and spiritually, we're basically visiting the future. And if we can visit the future, then we have a plan that's more likely to be practical, recognizing that we're only human. I can say I'm going to respond this way if this happens. But of course, when I get there, I may think, I really want to try more things. But that's okay because now you do have some idea, and it's more, you have a context now that will help you make better decisions. And that's the best we can hope for. I think that's a reasonable goal.
Gosh, I really like that process because I feel that is not happening a lot, and that people, yes, they have these diagnoses, but they don't know the impact of those down the line. And so what you're doing is you're getting them to think about, okay, when we reach this point, this may happen. What are your thoughts about that? And progressing down. And that's such a good thing to be doing because actually it helps prepare those people for when they reach those stages as well, rather than it coming out of the blue. So,
Correct. Now, to add on to that, when you look at these advancing stages, these different stages, we have an action plan for each stage. Mm. And so, for example, for asthma, there's an asthma action plan. For example, heart failure action plan, which includes symptoms that you can have experience when you're doing very well, when there's a problem, or when there's an emergency. Here's how you would recognize those. So these are already well established. And so I thought, why not use that for whatever clinical conditions an individual would have, my patient might have, for each stage.
Yep.
So the action plan becomes not only an empowering tool for you, the patient, but also becomes a platform for conversation, a practical conversation. So CPR, these other interventions fit in as action, part of the action plan. And if you don't understand, we have a concrete, a practical way to discuss that. Because I'm assuming that if you don't say anything, you understand. Well, probably 80% of the time, that's not true. I'm assuming way too much. And that's unfortunate for you because in a way, our relationship is such that you may not feel safe telling me that, Doc, I don't understand that. You don't want to feel stupid. You don't want to be, quote unquote, difficult. You know, I know Dr. Jones is busy and he's such a nice guy. I want to, I want to be a good patient. Yeah. And that's typical, but it's unfortunate because it's a disservice to your care. But it's kind of a pattern that we fall into. And I was hoping my system had one way to break through that. I practice on the south side of Chicago, and so we have a lot of underserved people in that community. Illiteracy is a problem. I started to find out that, okay, I'm giving you documentation. Here, take this, read this, and come back. It's not happening. But obviously, if someone has a literacy problem, that's an embarrassing thing to talk about. It's a lot easier to say, okay, Doc, okay. And I think I've really accomplished something, but I really haven't accomplished what I accomplished.
And it's quite often if you can get the patient to actually repeat back to you what you've discussed, then you start to get an idea of what their literacy and understanding is. But again, it's a time thing, so you don't have the time to do that. I know in New Zealand, I've worked in the health profession before I got into podcasting. So I was responsible, one of my jobs was developing for a region their advanced care planning system that's electronic that records this information. So when people move about, it can move with them, so when they move to a different region and all their health notes get transferred, this gets transferred as part of it. So that can just be picked up and added onto. So it has that, function as well. But we also have patient portals so that if you end up in hospital, you can give people access to some key information about your healthcare that your doctor has. And that can be part of it too. So if you end up in hospital unconscious, then your care plan can be accessed. So what is it like for you over in the States? Because I know we're talking to different audiences, so I don't want to be making that assumption that what it is like here is what it's like over there. So how do people keep track of their information over the years, especially if they're moving about and, life happens?
It would be great if we had a portable system like you have. Probably works best in managed care systems. And by managed care, I'm thinking of a type of system where your insurance, you or your employer or even Medicare pays a monthly premium and to a system, a delivery system. Mm-hmm. And that delivery system is set up to provide a range of medical services from physician visits to specialist visits to testing and so forth, and hospitals as well. And some of these are multi-regional. Mm-hmm. And if you happen to move from one region to another region, you're still in the same system. That's probably where that would work best. For most, that's probably not true in the United States, in which case you would pretty much, let's say you were moving to and you had to identify a whole new doctor and system. What we would do would either print out for you medical records, or ask you, as soon as you get to your new location, put us in contact with the doctor that you plan to see. And for me, what I would often ask, if you don't really know anyone in that area or have recommendations, then try to find the teaching center or university center, whatever, and get registered there. And then we have someone that we can contact. You give us permission to send them records, and we do that. Please don't wait until you have a problem. Be proactive. As soon as you get there, get to work, give us somebody we can contact, and then make an appointment, because you really want someone to know you, have been acquainted with you before you really need it, because then it becomes very complicated. It can be more complicated than it needs to be.
And I know there are also these information portals out there where people can store life in bank account. Yes.
That's great, but many don't. So
yeah,
if you get into that might be something that if you get into a system in your new location, look to see if they have that. And then we just want to integrate information into that. That's an excellent point.
But I know, but it's always, for those who can afford it as well, So when we're talking about
with our Medicare and Medicaid, this can be more affordable.
Oh, okay.
Yes. Mm-hmm. So, for example, that would be covered in your insurance, that type of access.
Fantastic.
It basically depends on the delivery system, whether they have that functionality as part of their service. Mm-hmm.
Yeah. Okay. So just good points for people to be thinking about, especially if they're in that situation and things like that. So look, we all think we're invincible, and there's a lot of bad stuff that happens, like accidents in vehicles, workplace accidents, strokes, early onset dementia, cancer is also a biggie. So there's a whole host of other medical conditions that can incapacitate you very, very quickly and suddenly without warning. So at what age should you start thinking about having these end-of-life conversations, or just preparing information for those eventualities that happen out of the blue?
Whatever age you are today.
Yeah.
Which is interesting. Obviously, we think in terms of those who are Medicare age and older, obviously, but it makes no difference. Now, what's interesting is coming back to that problem list. When you have an older person who's got a chronic illness already, okay, we can talk about that chronic illness.
Yes.
Now, for someone who's younger, that problem list can say something else. So, for example, there are really three major categories of chronic illness trajectories. One would be, health medical trajectories. One would be the cancer type, in which you maintain a high level of functional capacity until you become end stage. And then anywhere from, say, for a year or less, you have a sharp decline in your medical status and your ability to function and independence.
Yeah.
Then there's the chronic organ failure type. I would put chronic lung disease, chronic heart disease, dementia, for example, in that category. Then you have the frailty. Now, I wouldn't put dementia. There's the frailty dementia, which is the third type, with more of a slow decline over time, and actually tends to be the most frustrating for most of us. And that's where most of us will end up. And the frailty dementia type, I would say, is something we can think about no matter what age. So, for example, I was talking to one of my doctors I was teaching, and she said, you know what, most of my patients are not Medicare. Most of my patients are younger. And I thought, you know what? How about women? Frailty dementia, the osteoporosis risk.
Yes.
And we're seeing more of a problem with that for young women because of our diets. There's less milk. There's less physical activity. And so you can enter menopause with a lower bone density. So you're starting out with a low bone density, then it's going down from there.
Yeah.
So if we want to address frailty dementia, we want to really work with what can we do to help you manage that? Because osteoporosis, you don't have it now, but the roots and foundation are here. So I can start to talk to you about diet, exercise, how you can get more calcium, vitamin D, weight bearing exercise, so that we are setting you up for a more success in the future from the frail dementia point of view. Also, if we look at likely causes of death for different age groups, I went back, and because this doctor was mentioning that, I thought, I never thought about it. I've been thinking about older patients because for the last 15 years of my practice, it was basically geriatric. And so my mindset was there, but she kind of woke me up. And I thought, under 35 here in the United States, suicide is a cause of death.
Yeah.
Well, we have to talk now.
Yep.
And then also homicide.
Mm.
What are risk factors? We need to talk about that. And before this model of what I have here, I never would have thought about that. I would have been, as a physician, reactive. Someone that had a suicide gesture ended up in the hospital. Okay, now let's talk about, depression management and suicide, but the event has already occurred. Now I can be more proactive and talk to you about these things. So it's really shifted how I think, and actually has made my practice more interesting because I'm not just treating a guideline and not just making sure that I checked off these boxes, but I'm actually engaging someone.
Yes. Gosh, it's real life happening. And speaking of that, pandemic. So I heard the other day of somebody that was really fearful of re-engaging back into society, of being around people again, because probably they had an introverted personality type and was quite safe and comfortable behind the camera at home for months on end. And suddenly have to get back in front of people and really, really fearful about that. So I think what we're having as a result of what we've all experienced with the change in lifestyles and being at home and not having the same social contact, we've got a lot more things that are going to be coming out as a result of that as well. I think that we just need to be aware of. I just thought of that as you were talking.
I'm thinking it will probably be another generation before we really understand the trajectory of COVID and all its manifestations. When I was in medical school, which was back in the middle 70s, we were always told if you knew syphilis, you knew medicine, or if you knew tuberculosis, you knew medicine, because those infections would affect every single organ system. And so if someone had a symptom or a problem with any organ system, you'd have to include those as possible diagnostic things to look into. I think that's probably going to happen with COVID as well.
Yeah.
Early cardiovascular, bleeding disorders, lung disorders, and neurologic disorders we're already seeing. And if you think about shingles, it's 5 decades before that manifestation of chickenpox.
Yes.
So who knows whether COVID might have some of those. When we say novel, we're serious. We do not know.
Yeah.
And we'll have to see before we can really figure it out. So it's just something to think about. And actually, this is another quick aside. I'm really wanting to see what the insurance company actuaries are going to do here. Disability and life insurance. I think personally, it's so unfortunate that there were so many naysayers saying, don't cooperate with the public health authorities over managing this thing, because if we all end up with higher premiums because of the diseases that tend to come out of this and disabilities that tend to come out of this, that would have been rather unnecessary to the degree we might see it, simply because we were not as proactive as we were encouraged to be.
Yeah.
Those costs have yet to be seen.
Really good considerations there. I just think it's going to be so far-ranging right across the spectrum. Yeah, we're living in a new age now, I believe. Let's talk about some of the barriers patients may have to having end-of-life conversations. What do you find when you bring it up and say, let's have a conversation about this? What sort of things are you coming up against?
Well, it's very interesting. Once I had a plan, I became less fearful myself. So I'm thinking the first barrier is the doctor's own reluctance.
Yeah.
And the doctor is reluctant because they're afraid of how their patient might respond. So we're talking, not talking about a delivering bad news conversation, but talking now about the planning conversation. Most often my patient will say, well, doctor, why are you bringing this up? Is there something I don't know about? So their mind automatically goes to delivering bad news. And of course, my response is, no, I'm considering this part of good care.
Yeah.
And I always like to be able to, and what helps me as well in my own mindset is to put a positive spin. So I don't know if you've heard of blue zones.
No, explain to me what that is.
Yeah, National Geographic. You can look, your listeners can look it up, blue zones, in a Google search. But basically, they identified, I think, 6 areas around the world where people live to be over 100.
Oh,
it turned out that there was some controversy as to actually how long people live. But basically, I think the rules still hold true, that there were basically 9 things that these people were doing that improved their longevity. Everything from a plant-based diet to having good family connections, neighborhood connections, spiritual community connections, regular physical exercise. All of these things were factors. And guess what? None of them were in a pill. Both money. And these are all lifestyle things. And so I was able to include that information. Again, as I started thinking about the trajectory in the future, that's how I actually ran across this. And this is something we could implement today. So you can imagine how COVID has had a negative impact, because isolating people pretty much knocked out pretty much 3 of those 9.
Yeah.
Because people are not able to have the physical community and connections and some people, even their physical, if they were going to relying on the health club, for example, for their physical activity, they were no longer able to do that either. So it kind of gave me a heads up. Okay, how can we help people fill in the gaps? And I was able to be more proactive. So that was one answer to your question. Another answer I would say is, now I have an opportunity to empower you, because I'm able to teach you skills now and get feedback from you so that you have a better control over. So for example, if you have a particular condition, if you understand a lot more about how to take care of yourself, and at what point do you really need to call in a specialist or an expert, you're going to feel more comfortable. You're going to feel more confident. Now, for my company, because my last 15 years of practice, I was an employed physician, they were concerned about unnecessary emergency room visits, unnecessary hospital admissions. And for myself as a doctor, I felt I was asked to be accountable for something I have no control over.
Yes, absolutely.
It's like, okay, I've got this symptom, it's scaring me to death. I'm going to go to the emergency room.
Yep.
Or I might not want to go, but my daughter or son, who's my caregiver, they're saying, Mom, you got to go. Now, if they have more information, if you have more information about, okay, if you have these symptoms, this is what that means. And at this point, short of this point, you can manage it yourself. And you're clear about what those signs look like. If you're not clear, that's part of the conversation we're having when your doctor is.
Yeah.
And if you are clear, then you can make a decision that we know, yes, that was the appropriate time. So quick story I'm going to say about this. I would have for example, my COPD, my chronic lung patients come in to see me. And there's a green zone, yellow zone, red zone. Green zone, you're doing fine, keep your same treatment. Yellow zone, you need to be using your inhaler, maybe your steroid inhaler. Give me a call. Red zone, go to the hospital. and they would be clear about what move looks like and so whenever they come in to see me, I'd ask, are you green zone? Doc, I don't know, I forgot, Doc, tell me again. And so I review. Another time that I come in, are you green? Where are you now? Doc, I think I'm red zone. No, you're not red because you're comfortable, but I have a little cough, Doc. Well, it's not like this. Let's talk about what red looks like. I would say,
Yeah.
Okay. And every time they come in, I would ask that. And they would begin to learn and then get more comfortable with that. Another thing I would do for my frailty and dementia, whenever they come in, I'd say, okay, let me see you stand up and sit down 10 times. Because I'd given them instruction to do this at home. Oh, Doc, I forgot. I know I should have been doing it, but I wasn't. I said, okay, let me see you do it. Oh, Doc, I can't do 10. Okay, do 3. I want you to do them at breakfast, lunch, and dinner. And every time they come in to see me, so eventually after a while, they know they're going to hear this from me. And they'll walk in, Doc, I've been doing my stand-up and sit-downs. Then I'll ask them, how does that make you feel? Do you have less knee pain? Yeah, I have less knee pain. I'm a lot more comfortable going up and down stairs. I've got the result I was looking for. So that's how you kind of take a bite out of it. You kind of teach a little something, and then we actually work with it, and we're engaging. And I can find out if they don't understand. I'm not slapping wrists. I'm not judging. I'm just saying, okay, let's work on that. Okay, we can do this.
Oh, that's beautiful. I think everybody's listening is going to be wanting their doctor to be like you. Having those beautiful conversations.
They can push those conversations because sometimes we do have to hear it from our patients.
Yes.
Unfortunately, I'd have to say some of us physicians are not really receptive. That is unfortunate, but you're dealing with human beings on that end as well. And if you have the option, try to get a doctor who can be more receptive. Sometimes you can, sometimes you can't, or sometimes it's more difficult. But I think that's an expectation you should keep for yourself because I think that's valid.
Yeah, I think that's a really, really good point. Okay, so on that note, how can people empower themselves when they go to their doctor and have these conversations? Because many people still consider, the doctor like a demigod, and, we just sit there and listen to what he's saying and go away and hopefully do as he says, but maybe not.
Good questions. Question number 1, how am I doing?
Yeah.
And you want to get a good understanding of that in your own language. What does it mean? So, Doc, okay, I'm doing this way now. How can that change in the future? What would that look like if it should get worse physically? Yeah. And then I want to be able to give you feedback in terms of how that would affect my life if that happened. And I need to think about that myself. That's kind of scary, but we do want to think that way. And then the last question is, what do I do? So you might have a treatment plan already, given how you are doing, and that's working. Maybe you have some concerns. Maybe you think, okay, Doc, I'm following your instruction. I'm really worried about these side effects. I'm really worried about, I read something here, I heard something there, my nephew said something, and they saw something on the internet. What does that mean? What would I do with that? What do I do with that information? Then also, what do I do means, do I have a good understanding of what the action plan is for me? I'm doing this way now, but we want to think there's a green zone. I'm doing fine. There's a yellow zone with my condition where I'm not doing as well as I should be. I'm afraid of this, this, and this. And then there's a red zone. Doc, at what point should I really try to go to the emergency room?
Sure.
So you want to actually think about that. We have in the United States, I'm not sure if it's available internationally. I think it might be 5 wishes. Are you familiar with 5 wishes? That's a booklet of about maybe 8 pages, which I like quite a bit, which allows you to write out your plans. So that is an advanced care plan book.
Yeah. We have
your doctor will love you. Probably give you some praises. If you completed one and gave that to them, they can scan it into their system. And I would recommend if you have something like that, let's say you don't have a system like you were so instrumental in putting it together, scan it and email it to yourself.
Yep.
And that way you can always email it to whoever needs to have it. So I would recommend personally 5 wishes. There are a number of online options as well that you can find if you wanted to do that. There are apps that have this end-of-life planning and advanced care planning apps. You can find those, and those allow you to be portable as well. Send it to whoever needs it. But 5 wishes is a good place to start.
Oh, that's such a good suggestion. Thank you for that. That's really good. Now, we briefly touched on like some of the barriers that doctors or physicians are facing that would be a barrier to them being able to set up these types of end-of-life plans. What other factors are there that the average patient should be aware of? Because, some people are going to go expecting these things to happen. And I just want them to have a clear understanding why they also may not be happening.
I think what you're asking is someone may want to have a certain medical intervention and they're wondering why it might not be happening. Is that what you're asking?
Well,
expecting certain processes to happen.
Or they go in and they want to have an end-of-life conversation with their doctor. And are there some additional barriers that we may not have already discussed that may be influencing why a doctor is unable to do that? I know that we talked about the time thing, and often there's a lot of information that needs to be imparted and discussed in a very short space of time. But then you also touched on burnout. So there are a lot of physicians who are really under the pump, how they're working. So can you just share with us some of those types of barriers?
Because with the burnout for doctors, there's several factors. One being lack of time.
Mm-hmm.
Another being feeling like we're responsible for something we have no control over.
Yeah.
And related to that is, in my mind, loss of a sense of mastery. That's one.
So explain that.
Broad sense. Yes. So in our training, part of our training is to get us to the point where we are masters of our discipline because lives depend on it. So that's kind of how that goes. Dr. Jones, this is your patient. You need to be able to handle whatever happens with them because they're your responsibility. And in the sense if something goes wrong, there was something you didn't do right. So we try to learn as much as can. We can get all kind of spastic and out of shape with all that. One thing about experience is we understand that, there's only so much you can do. And you really want to try to work with other team members and so forth so that we have the support. We start learning how to maybe refer sooner if this is something that's kind of beyond my training. But you want to have a sense of mastery. My experience when I became employed is some of that is taken away because I have less control over what I can do. I may want to refer to this facility. Well, that's outside the network. I can't do that. I may want to prescribe this. Well, that's not on the list of medicines that we can use. So you can't do that. And other things, I don't have as much control. I might want to spend 20 more minutes with you. I can't do that. And so I feel like there's less control over what I can do. And so I'm less creative. That's one reason why I think it's good for doctors, everyone to have some degree of entrepreneurial effort that they've got out there, because I think thinking like an entrepreneur helps you to be more creative, to look at the glass as half full, not half empty. Do I have that right?
Yeah.
Like optimism. It's like, you know what, there's a solution somewhere. I'm not going to just settle for what I see if it's not working. What can I do to actually be of service, bring more value? I think entrepreneurial thinking is something that helps. To your answer, though, I would say if your doctor is not there yet, get 5 wishes or some other and be proactive and get your own advanced care plan done. And that can become a point of conversation with your doctor. And so,
Yes.
for example, in the 5 wishes, they'll ask, would you want to have a ventilator? Would you want to have this and that? You can go to your doctor and say, you know what, this is how I responded to that, but can you tell me more about what happens with CPR? When it's useful, when it's not? Can you direct me to some resources that I can actually learn more? And that way you can start to educate yourself. And so being proactive is a good way to approach that. And by showing up to your doctor with this, I think right then your doctor also feels relief that this is not something that's off limit. This is not a barrier. My patient already gets it. And we can actually move forward. And so you've actually taken steps to make a huge dent in that barrier. Does that make sense?
I think also, yeah, absolutely. And I think also when you were training, things were pretty concrete and like that. Now we're living in an age of where there is so much information that people have access to. And rightly or wrongly, there are a lot of people out there making their own diagnosis of what's coming on with them.
Can I say something about that? Actually, I think that's a real opportunity for collaboration. I know some doctors, I've heard of some colleagues, or actually heard remarks from colleagues where if a patient comes in with something from the internet, they feel insulted. I'm the doctor. That's crazy. I look for that as an opportunity.
Mm-hmm.
Because you know what? Even if I don't want to hear that, you're looking at that,
Mm-hmm.
And so I might as well be engaged. I can be your consultant.
Yeah.
So if you come to me with something from the internet I think does not apply, then I can take a few minutes to say, I don't think that applies to you. And here's why. Here's why. So that now you're a better decision maker about this. Now, this is especially true sometimes because we have a number of companies where in the United States where people are selling nutraceuticals, for example, a lot of herbals and things like that. And I'll have a patient who has a relative who is an agent for these things, and they're selling like $50 a month of these vitamins. And they'll bring in and say, Dr. Jones, I'm taking this. Is this okay? And I'll just take a look and I'll say, you know what? Okay, I see these, but you're already taking vitamin D, so you don't need that. You're already taking this. I don't think you need that, but you could probably benefit from this. I don't see the harm. I don't really necessarily see the benefit, but if you want to spend the money, I don't see the harm. They want to support their relative. I can get that.
Yeah.
But also let's work with it. I'm not going to say, throw all that away. That's nonsense. Well, no, that's not right. Right. I want to help. Ultimately, I want to use a system here that makes you a better decision maker.
Good.
If you're a better decision maker, you're empowered and you help me.
Yes.
And that's collaborating. So the whole goal is to help you be a better decision maker.
Yeah. I'm definitely one for collaboration. I think whether it's amongst your own peers or whatever, because you can't know everything. Come on. And sometimes it's just things that just don't fit into a box. They're just really obscure.
I've learned something. I had a patient came in. She said, Dr. Jones, I've heard that you can take mustard for night cramps. I said, I don't know. And I can have my computer out. I said, well, let's go online. Let's check it.
Yep.
They were right. They were right. And so I looked, and I think the thinking is that it's the turmeric in mustard that gives you the relief.
Yes.
I thanked my patient. I said, I didn't know this. You've taught me something today.
Yeah.
And, hey, and then I started recommending for other patients.
Yeah.
Oh, this is an opportunity really for me. And also I would always appreciate it because I can't keep up with everything that's coming up on the internet that are facing patients. So when they bring this to me, I've become aware now, I didn't know that was out there. Okay, now I have a chance to process that and kind of see. And so my patients actually are helping me by doing some of that footwork, by bringing that information. That makes me a better doctor to serve other people.
Great. I love your attitude. So good. So open. Okay. So we have just had a wonderful, wonderful conversation, and I could keep talking to you because there's so many other paths we can go down. But, for the sake of this interview, I think we're just going to wind it down now. So I would like to finish up with a couple of quick questions. So what is the best thing that has happened to you either today or this past week?
Actually, one thing that happened to me this past week was we had a family conversation because my wife's mother is at an age where this life is more challenging for her. And the whole family happened to be in town, all of her children. And so we had a chance to have a conversation which helped everyone to kind of be on the same page with what her limitations might be and what some steps we can take moving forward. And one thing about taking care of a chronic illness or someone who's aging is that it's not a matter of fixing it. It's a matter of adapting. And how can we think in terms of adapting? If we want to fix it, we end up in very frustrating situations. And sometimes our loved one who's aging, we may try to take away their independence because that's more of Mom, you shouldn't be doing that. You shouldn't.
Yes.
You shouldn't be cooking, Mom. Well, let her do something, because this is something that's important as part of who she is. If there's risk, maybe we can find some way to help her. Maybe she can't clean the whole house, but let her do what she can do.
Yep.
Dad, you shouldn't be doing this. Dad, sit down. Don't, no, that's not how they're built.
Yeah.
How can we help adapt to the limitation that's there? Even mentally. Mom, you shouldn't be talking like that. Dad, you shouldn't be talking like that. Well, what does that mean? What are they really trying to tell us? What are they really trying to communicate?
Yeah.
How can we help?
Yes.
So it's really not about fixing. It's about adapting. And adapting for the caregiver and loved one is really a two-way street because we have to adapt too.
Yes.
The doctor has to adapt. I will say this, we're emotional also.
Yeah.
And a lot of times it's hard for us to deliver that bad news because Miss Jones, Miss Jackson, Mr. Morgan, I've known them,
Yes.
Mr. Morgan's a jazz drummer. We always talk about that. And I know jazz and now I hear I see from the emergency room, he's got this cancer in his lung. I have to step back. It's like, oh, I don't want to know this either. And unfortunately, some doctors can't handle that.
Yeah.
Personality, we don't get modeled in our training. And that doctor may actually abandon you.
Mm-hmm.
Not intentionally, but it's just emotionally difficult and they don't know how to process that. They don't have the resources. And so you start finding the doctors less available. Or unfortunately, I've talked to a number of hospice nurses who would say they feel like the patient who was referred to them dumped. The doctor just basically said, okay, there's nothing else I can do for you. Go to hospice. And the patient said, huh? What are you talking about? What is this? And the doctor is just kind of withdrawn because they don't really know how to handle what for them is an emotionally difficult situation. So I just want to give your listeners a heads up as well about that and make that a better process.
Yes.
Hospice is just another service that is appropriate when cure is not possible.
Yeah.
We want to give you a soft landing. We want to give you the opportunity to really have a strong legacy to your loved ones.
Yeah.
So that your life has meaning. Because your life has meaning, their life has more meaning.
That's beautiful. I'm glad you shared that. Thank you. Okay, either professionally or personally, what is your proudest moment today?
Well, I just had another grandson born about 2
Congratulations.
months ago, and we have another on the way in December, Christmas week. So that's what we're really looking forward to.
Oh, wow. New life. Babies, they have a way about them, don't they?
Absolutely.
Okay. What is your go-to when you're having moments in your day where your day is just turning to custard, where things are not going as planned? What is your go-to to be able to turn that around, pivot out of it?
Phone call to friends and members of my support system. Certain things I can read. I do have audiobooks that I can go to, and my wife, Roberta.
Oh, lovely. Oh, I love that. Okay. And what takeaways would you like to finish up with, leaving our listeners with?
I would say they're worth it. You're worth it. Even if your doctor is not able to really meet that need, keep putting it out there because you are worth it. And to the extent that your doctor is able to adjust to that, your doctor may already be on that page and really ready, but just haven't had the opportunity and just welcome it. But if they're not there yet, then that expectation, I think, is definitely a valuable expectation. Don't lose it.
Yeah, wonderful. Dr. Forrest Jones, I would like to congratulate you on the wonderful work you are doing to help other physicians have these end-of-life conversations. I know we didn't get into that side of it, but I think what we have talked about today is just going to provide some really valuable information to our listeners, especially if they're in that scenario themselves and they want to be able to advocate for themselves or their loved ones. So thank you so very much for taking the time to share that with us today.
Thank you so much for having me. I certainly appreciate it.
Hey, thanks for listening. If you enjoyed this episode today, be sure to share it with others. Hit the subscribe or like button so you can be notified of each weekly episode. Also, let me know how I'm doing, especially if there's more you'd like to know that perhaps we didn't get time to touch on today or in past episodes. And if you're after resources to help you out on this journey, or more about the energy healing work I do, hit the Healing to Be You link. That's the word healing, 2, letter B, letter U.com. So until next time, be kind to you, and thank you for joining us on the beautiful side of grief.